So today I'm going to be discussing the basic management of burns. So basic management starts with respiratory compromise from superheated air or smoke inhalation. Full thickness burn to the chest, compromised breathing. So we have to obtain labs, complete metabolic panel, and complete blood count, type and cross match for the blood for transfusions, carbohemoglobin levels, carboxyhemoglobin levels, which give us that carbon monoxide poisoning level, cardiac enzymes, troponin I, T, and creatine kinase, MB, and myoglobin. Chest X-ray will show us the pulmonary effusion, electrocardiogram, the arrhythmias. We have huge fluid shifts, potassium and sodium going in and out of the cells. And the myoglobin. The myoglobin from damaged muscles will lead to kidney injury, so that has to be flushed. So to initiate fluid resuscitation, we have 2 16 gauge needles. 2 of them. Okay, hold on. Is it yellow? 2 needles. 2 needles. 16 gauge. And to initiate the fluid infusion. Also, they probably will consider the central line if the burn is more than 30% total body surface area. Then the Foley will be placed to measure urine output. It's very important to monitor the kidney function, and the output is a great marker to determine how effective the fluid management is. Fluid management. So nasogastric tube, if they have a paralytic ileus, paralytic ileus, then the contents may go back, and they will plummet the contents of their GI tract, and of course control their pain. So here we have a model which all of the treatments were applied. So we place them on probably non-rebreather mask 100% to displace carbon monoxide on the hemoglobin. So injury to the chest compromise the expansion of the chest, so escharotomies will be performed, or fasciotomies. So we have an axis, the venous axon 12 gauge, or central line if we are if we have a more than 30%, if the patient has more than 30% injury. Then the nasogastric tube. The nasogastric tube is placed. We have a urinary catheter to measure the output. We'll monitor the pulse ox. It may be falsely high because of the carboxyhemoglobin levels, so that's why we're checking them with the blood draw for carboxyhemoglobin levels. And then we just take the reading from the pulse oximeter, which is 95, subtract the percentage, and we get the true SpO2 value. So next, fluid resuscitation. In fluid resuscitation, so we're going to use this formula, percentage body area burned multiplied by kilograms and of the patient's weight, and 4 milliliters per kilogram. And this is called Parkland's formula. So we're going to use the Ringer's lactate, which contains the necessary electrolytes for the transfusion. So maximum percentage of Parkland's formula is 50. And if it's more than 50, then other formula will be used. We should substitute any fluid already given from the total IV. So in ambulance and emergency department, we'll administer fluids, and we will subtract those fluids from the first half of fluids being administered. Alright, so administration, we'll administer, so the total volume, we'll administer first half. So if we have 10,000 milliliters, we'll administer the first 5,000 here, and we'll administer the next 2,500 here, and then we'll administer the rest here. So for pediatric patients, Parkland's formula will include 6 milliliters per kilogram, not 4. Urinary output 5 milliliters per kilogram, 0.5 milliliters per kilogram per hour. It's the best monitoring criteria. So if our patient was 90 kilograms and we have 0.5, the output should be minimum 45 milliliters per hour. Okay. Treatment of the wounds. Treatment of the wounds is done with silver sulfadiazine, and it's the antibacterial and reduces the infections. Then because of the leather-like, the inelastic leather-like skin has to be treated with escharotomins, especially for circumferential full-thickness burns to the limbs or fasciotomies. Can be used. So also if the extremity was burnt, it will swell up. It will enlarge, and not only will it enlarge, the blood vessels inside, the blood vessels will be occluded because of the pressure on them. They will be pressured by the edema, and it will close the blood vessels, and necrosis will start. So if the, let's use the yellow, if the fasciotomy or escharotomy is performed, they cut the area here, in the fingers. It will allow the tissues to expand and will not occlude the blood vessels. Tangential excision and skin grafting, performed for deep dermal and full thickness burns that are too large to heal rapidly by secondary intention. So they will basically do the grafting, take the grafts from cadaver. That's the homograft, basically the same species. It could be the xero graft, which is from pork, and it could be also allograft. So if the patient has available areas of viable skin, they can take it out of there, and it will heal something like in 2 weeks. 2 weeks the area will be healed, and they can take the grafting from that area again, skin graft from that area again. Also, there is such thing as synthetic skin. Or no, not synthetic. It's called artificial skin. Artificial skin, which is basically a silicone on the top as a skin, as the epithelial layer, and then like a matrix acting as a dermis. Silicone matrix. Silicone matrix. Also, there can be new treatment where they take the cells from the patient, take them to the lab, grow them to large amount, and bring those cells back as a sheath of skin. It's called cultured epithelial graft. They take the cells, the epithelial from the patient, they take them to the lab, they put them in special media with the growth factors that will stimulate the skin cells, the epithelial cells, to proliferate, and then in about 25 days they will expand to 10,000 times the tissue, and so they can bring it back and put it back in the patient. So if the injury happened to the face, then immediate treatment would be airway breathing circulation, putting the tracheostomy or orotracheal access, giving them 100% oxygen, non-rebreather, and monitoring for acute respiratory syndrome, stabilizing, removing thread, starting IV, emergent up to 48 hours. That's the phase. Okay, and now that's our lactating ringers that we're going to use, and this is the all potassium hematocrit. We're going to monitor urinary creatinine, urinary output, ABGs, increase in heart rate, decrease in blood pressure. If they're on hemodynamic monitoring, we will monitor the central venous pressure, and GI mucosa will lead to, because of the decreased supply to the GI mucosa, curling syndrome can occur, which is ulcers from decreased perfusion. So, burns to the face. Patient will have stridor, hoarseness, cherry red skin. This picture, by the way, was obtained from the OneNote. OneNote provided the picture. So, cardiac output. Carbon monoxide poisoning, and here's the hemoglobin and carbon monoxide are pushing away the oxygen. So risks are hypovolemic shock, respiratory distress, and compartment syndrome. So hypovolemic shock IVs, respiratory distress, our orotracheal Kiel axis, and then compartment syndrome fasciotomies or escharotomies for treatment. So again, come on. And this is basically a little diagram of escharotomies and fasciotomies, where all this on the patient is a leather-like skin, and they do the cuts to let the tissues to expand and fill out with fluid, and it will go away after several weeks, months. And then on the hand, some fasciotomies. So escharotomy, treat full thickness circumferential burns. Escharotomy performed to release pressure, and it's performed by trained physicians, not by nurses. Fasciotomy, cutting away fascia to release tendons of pressure. So a little diagram, what steps are taken. So burn, stop the burning, start the IV, get the labs, Foley, nasogastric tube, assess the airway, breathing, circulation, any disabilities, the thoracic damage on the vertebra, the injuries on the vertebra, exposure, good